much.
Thank you so much. Thank you. I'm really happy to be here. My name is Scott Lee, and I'm a psychiatry resident at Harvard South Shore, which is affiliated with the Veterans Affairs Boston Healthcare System, the VA Boston Healthcare System. And based off of this work with our outpatient ketamine clinics, I'm hoping to carry forth this work and bring it into VA Boston informed consent practices, as VA Boston is a pilot site for ketamine usage in mental health. So it's a pleasure to be here. And I'll start sharing the slides, and David can take it away initially.
Sure. Thank you, Scott. And a brief introduction. My name is David Mathai. I'm currently a postdoctoral research fellow at the Johns Hopkins Center for Psychedelic and Consciousness Research. I would say broadly, my interests are in clinical applications of psychedelic medicines. A lot of my interest in ketamine started when I was in training at Baylor College of Medicine. Had the good fortune of working with Sanjay Mathew over there. And I've had the opportunity to explore different aspects of the psychiatric use of ketamine. Again, this paper was recently published in the Journal of Affective Disorders. It's a long one. They're one of the few journals who would take all 4,000 of our words. Would recommend that you all read it. There's a lot more in there that we won't be able to get to in this discussion, but we can go ahead and start with that, just briefly outlining some of our findings and some of the idea behind this project. Right, so we'll really follow pretty closely to the structure of the paper. You can go ahead. So many psychiatric uses of ketamine are off-label. This typically means an unapproved indication, dosage, or form of administration. And this has been an intense area of focus and scrutiny around psychiatric practice. This isn't strange or novel in our field. Many psychiatric medications are used in off-label ways, but what is perhaps unique to some of the interest in ketamine is that we are still very much settling into its use as a psychiatric drug and what those various parameters are. So this study is really an extension of that interest, of that curiosity to characterize what some of these patterns are, to look at different questions that might be relevant as we further explore this. Go ahead, Scott. So on the one hand, off-label drug prescribing could shift the risk-benefit ratio of medication use toward adverse drug events. Worded in this very specific way because we may have characterized some of the issues around safety and tolerability when we explore ketamine for very particular indications, say depression. And some of what we learned there about the safety and tolerability data is going to be applicable to, say, ketamine for anxiety, assuming there are some similar parameters of use. What might not be as well understood is the relative benefit, the additional benefit afforded by the use of ketamine toward that indication. So really, we're working with this idea of the ratios, thinking about the relative risk, the relative benefit. Additionally, off-label drug prescribing is a tool for mental health providers, an opportunity to be flexible, to use clinical judgment, apply expertise in a way that serves patients who are in need and might be caught in gaps of regulatory process. It's very likely that most of the things that we want to explore with ketamine won't be explored. And this is particularly true when we think about ketamine as an off-label drug, and there not being special financial incentive to move forward with some of these studies. So when we think about adequate supporting data for the off-label use of ketamine, there's no easy answer to that. And it's a highly individual question. I think the most important thing is there is that process of wondering what is the justification behind this use? What does that look like? Typically, we think of stronger forms of data, like data from randomized clinical trials, from documented clinical uses of ketamine. But ultimately, this is an individual decision with liability judged on a case-by-case basis and left in the best judgment of the provider. Go ahead, Scott. Okay, so that brings us to informed consent, which is really at the center of these processes when we think about these uses of ketamine that we're still exploring. Serves many different functions, ethical, legal, administrative functions. Go ahead. And really boils down to looking at the risks, benefits, and alternatives of treatment toward the goal of toward collaborative decision-making around treatment. And that brings us to written consent documents. So many of you have used this in practice, I'm sure. They're neither necessary nor sufficient for consent process, but can be a really helpful tool towards larger conversations around drug consent. They can provide structure for the consent process. They can benefit both patients and prescribers alike. And interestingly, they can reveal emerging practices too. This is an idea we got from some colleagues at the Baylor Center of Ethics when I was there in residency. Scott was a medical student there. That's where we first met. But this is a chance to think about emerging practices. This group was at the time looking at LVAD implantation and looking at consent conversations and processes around that. And we thought it was a really unique way of thinking about emerging uses of ketamine, and also a really rich source of data and information about a practice and a field as it continues to evolve. And so those were really the goals of our study, to do this exploratory analysis of informed consent documents, and also to start a broader conversation around what are the key elements of consent and what does sufficient consent look like perhaps for different clinics and different providers. Go ahead, Scott.
Yeah, so that is a beautiful summation of the background of our study and where we were coming from in terms of approaching this study. And now I want to share a little bit about our methods, specifically the recruitment process of finding these clinics, and also the analytic framework that we developed in terms of analyzing these informed consent documents. Starting with the recruitment process, the primary recruitment source that we used was the American Society of Ketamine Physicians, Psychotherapists, and Practitioners, the ASKP3, which is a professional organization of providers who utilize ketamine for mental health disorders and pain. The majority of these clinics are based in the United States. However, some have an international presence, which led us to having an exclusion criteria of international forms, as informed consent processes can vary among different countries. So that left us with 288 clinics identified, and we personally emailed each one from August of 2020 to December of 2020. And from that emailing time, we got 25 positive responses, and of those 25, 2 of them had international forms, so we excluded those, which left us with our sample of 23 United States clinics, United States outpatient clinics. So that kind of sums up our recruiting. In terms of our analytical framework, it was really a composite of 3 best practice guidelines: the ASKP3 standards of practice and the therapeutic use of sub-anesthetic ketamine, i.e. mental health, pain. The second one was the Ketamine Research Institute, or KRIA, and their ethical guidelines for ketamine clinicians. So their research institute, they also provide training for ketamine-assisted psychotherapy. And the third best practice guideline was an expert opinion on ketamine and esketamine in treatment-resistant depression, which was published in the American Psychiatric Association journal in 2021, so just last year. So kind of taking a step back and looking at these 3 best practice guidelines, The first two, the ASKP3 and the KRIA, some of the key points that we derived from these guidelines that really informed our analytical framework were as follows. The first was this emphasis on having specialty training in ketamine administration, specifically for mental health disorders and pain. The second was this necessity really for a thorough medical and psychiatric evaluation prior to the administration of ketamine or S-ketamine. The third was having robust management plans, safety protocols before, during, and after administrations, things such as whether, noting whether like patients, like cautioning that patients shouldn't drive or operate complex machinery after a ketamine or S-ketamine session. The fourth was this having intentional collaborative efforts with primary care providers, psychotherapists, anyone in the mental health interdisciplinary treatment team, just making sure that they were on board and knowing that these patients were undergoing ketamine or S-ketamine treatments. So that kind of sums up our first two sources. The third source that we had was this expert opinion from McIntyre et al., published in 2021 in the APA journal. And it synthesized the evidence of ketamine and S-ketamine in treatment-resistant depression and also provided an expert opinion. In addition to really kind of emphasizing these points, the specialty training, the medical evaluation, the psychiatric evaluation, this expert opinion also kind of gave us a great sense of where ketamine was in terms of the literature and what we knew about it in the mental health context. Indications, in terms of indications, the most evidence for ketamine and S-ketamine was for major depression without psychosis. In terms of routes of administration, the most evidence thus far at this outset was for intranasal S-ketamine and intravenous ketamine or IV ketamine. In terms of efficacy, and this was really helpful in giving us a sense of how to best counsel patients who would be interested in starting ketamine or S-ketamine for mental health purposes. And the literature has shown that these modalities have a really rapid onset within 1 to 2 days of targeting depressive symptoms, and that the long-term safety, efficacy, and tolerability profiles are up to 1 year for intranasal S-ketamine and indeterminate evidence at this outset for intravenous ketamine. Finally, other mental health indications are still being explored, and that was something that was important as we looked at the results section, as indications was something that we had stated that we would be analyzing as well. So that kind of sums up the composite of the 3 best practice guidelines. And as David had mentioned, we also derived a lot of our document from the ethical principles from Fedson's informed consent document analysis on left ventricular assist devices. So putting all of these forms together, that led us to this beautiful analytic framework, which we now further separate into content, procedures, and syntax. And we did an item-based analysis of each one that included each one of these items right here. So I'm going to take a little bit of time just to give you a sense of what we were looking for in terms of each of these pieces of our analysis. Starting with the content, the first thing that we were looking for are the discussion of risks, short-term risks. For a really complete form, we decided that the form should really include at least 1 sign or symptom from 3 out of 5 organ systems, cardiovascular risks, respiratory risks, gastrointestinal risks, neuropsychiatric risks, and immune system risks. That covered our short-term adverse effects. Our long-term adverse effects, we thought a complete form would at least have 2 of 3 of the following. Discussion of the addiction or abuse potential, genital urinary side effects such as dysuria, frequency, urotoxicity, and neurotoxicity, such as concern for long-term cognitive impairment, particularly if this was given in a pediatric setting. So that kind of covers our risks and our short-term and long-term risks. Benefits, whether or not these firms had noted these benefits, and success factors. So that's like where we kind of had derived like from the 2021 APA guidelines, where they had mentioned, like the efficacy was 1 to 2 days. In terms of alternatives, whether these firms had noted these alternatives and associated risks and benefits, and in terms of voluntary nature of treatment, whether they had noted these as well. So that kind of sums up our content. Our second piece was the procedures, and this was where really we were looking at whether there was a discussion of a role of the medical evaluation, the psychiatric evaluation prior to treatment, alongside the requirement for on-site medical support during administration and on-site psychological support during administration. We also included administration protocols as well. So like dosing adjustments, how many anticipated doses, that kind of stuff was included in administration protocols. And finally, with reference to like the intentionality to collaborate care with other providers, whether or not forms considered psychotherapy as a possible adjunct to treatment. Our final piece was syntax, and a lot of this was derived from general ethical principles and from the Fedson paper and just in general as well. And we noted whether these forms had included all of these items right here. So that in summation kind of sums up our analytic framework. And now I'm gonna discuss a little bit about the results of what we found. I'm gonna break this down into 3 sections: the clinical characteristics, the results of the analytical framework I just discussed, and a synthesis of all of this stuff. With regards to clinic characteristics, we found that all 4 US Census regions were represented in our 23 American clinic sample. With regards to routes of administration, the most predominant form was intravenous at 65.2, following intramuscular 34.8, intranasal and oral at 21.7. With regards to the mental health training of participating clinics, 40% had a psychiatric prescriber on board, 25% had another type of mental health clinician, such as a therapist on board, and 35% had neither. And just kind of keeping this in mind, the ASKP3 is for mental health, ketamine for mental health and pain. So that kind of explains this like wide distribution right here. Finally, in terms of psychiatric indications, we found that all of them had listed major depressive disorder as an indication for ketamine and esketamine, 91.3 PTSD, followed by generalized anxiety, OCD, bipolar, and substance use disorder. So the second piece of our results was just kind of doing the item-based analysis of this analytical framework that we had developed. And just to refresh your memory, this is what it looks like. And so first starting with the content, we saw that for the most part, like most of these forms were hitting complete when it came to short-term adverse effects, noting benefits, and noting the voluntary nature of treatment. However, long-term adverse effects is really where they started to struggle a little bit, along with noting alternatives and associated risks and benefits of that. For our second piece of the framework, with regards to the procedures, again, we saw like that the completeness of particularly like the evaluations and the availability of on-site medical and psychiatric support was not well represented in the documents that we had analyzed. However, most of the documents did a really good job of delineating administration protocols. Finally, with regards to syntax, most of these documents did quite well with note of readability, which I'll discuss a little bit, just in a little bit of time. So kind of like synthesizing everything that we had discussed, some areas of opportunity for improved communication in terms of content would be the communication around long-term adverse effects and communication around possible alternatives. In terms of procedures, again, just like the communication around the role of a medical evaluation, psychiatric evaluation, and on-site support during the administration and after the administration would be an area of opportunity. And finally, in terms of the syntax, as you had maybe had seen, 0 of the 23 had a readability score at or below the 8th grade reading level. We decided 8th grade because the average American reading level is at the 7th to 8th grade level. And in terms of figuring out the readability scores, we had used a composite of 3 distinct readability indexes: the Flesch-Kincaid, the SMOG, and another one as well that it's not slipping my mind at the moment, but it was an average of those 3. And I think from our analysis, the overall average of the 23 clinics was at a 14th grade level, which is the college sophomore level. So this kind of sums up the areas of opportunity for improved communication. And now I'm going to turn it back over to David, and he's going to finish out our talk with a little bit of the discussion piece.
Scott, you can go ahead and click. So you can see we created this sort of grading rubric that was in a lot of ways aspirational, I think, looking at a couple of different sources, different ideas on what adequate consent might look like, and still found that in spite of that, clinics addressed a majority of items. Go ahead. Scott, although this varied some for individual clinics and across the different domains that we discussed. Go ahead. So important limitations, probably the biggest one has to do with sampling and sampling bias. This is a sample of 23 American clinics. It's from a convenience sample. It might be fair to say that clinics that were more willing to share forms with us might have a more rigorous consent process to begin with. It's also possible that there may be some underestimation in our analysis of a larger consent process. Like we talked about, written consent is just one piece of informed consent overall. There may be conversations that aren't being captured by these documents, and especially ongoing conversations if we think about consent as this continuous collaborative sort of process. Go ahead. And there were a few difficult questions that I think were implicit in some of our work and in some of our findings. One was how controlled are controlled clinical settings. Often we talk about certain risks, neuropsychiatric risks, risk for addiction, as isolated to very particular uses and doses of ketamine in recreational settings, for example. And while it does appear to be the case that many of these risks are mitigated in clinical settings, I think we are still learning and understanding as a field what these risks look like. Go ahead. Who is the reasonable physician? So when we think about standard for appropriate procedure, in many places in the US, this is often what might be expected of a reasonable physician, someone with comparable training who's working in a similar clinical community. But what I've found as I've explored this work is that these ideas can vary widely depending on who you're asking and depending on the setting. And for this reason, I think it's important to have these broad interdisciplinary sorts of conversations where we can really understand some of the tensions that exist, and better understand what different thoughts are on appropriate uses of ketamine. And then again, what is adequate supervision? We talked about medical and psychological support, and we defined these fairly loosely in our analysis, but it is unclear what exactly these infrastructures should look like. And it's important to also think about, what is best care and maybe what is good enough care too, when we think about the access, the availability of treatment. So these are questions that we're actively exploring, This is something I'd maybe be curious to hear about if others in the audience have thoughts on this as well. Alongside that, what is adequate training for these kinds of uses and applications of ketamine? It's still not yet a routine part of most training programs. So just thinking again about what does the team need to be equipped to handle, and what kind of training puts them in a position to handle different aspects of the use of ketamine. Go ahead. And then finally, just a few future directions. The largest one would probably be to replicate in a larger, more diverse sample. And then, go ahead, Scott. Also to think about how these ideas, the rubric, the paper could be used. Our hope is that it could be used toward starting some of these conversations, thinking about consent process on a clinic level. Maybe could be used toward developing templates or standardization as we continue to think about best practice with ketamine as a field. So that's most of what we have to say. Thank you all for listening. I want to open some time up for questions. Thank you.
Great. Okay, that's really helpful. Thanks. I mean, this is a really, really important topic, isn't it? And it's important for the stewardship of our field, I think. You know, please do. Let's have some Q&A. I can't see any questions from the audience as yet.
In the meantime, the people are gathering some thoughts. I have some question, if you don't mind, Robert. Thank you very much, David and Scott. I think it's such an important, interesting topic for all of us working with ketamine to discuss. Did you notice, you know, what, for example, is the timing of the consent form? It's something that is usually administered at the clinic right before the treatment, or is something that takes place more at the time of the assessment?
I don't think we actually know, because that wouldn't be present in the consent paperwork itself. So that might be something, if we had some additional information, conversations with these clinics about the timing of their consent process. That is an interesting question. Why do you ask, Sarah? I'm curious.
I was curious, you know, I just feel, I think probably every clinic has also done a different procedure for assessing this patient, I would assume. So like it goes from like the kind of the documents that are required for referral, but also then at the time of the assessment they do at the intake, let's say, if we can put it this way. So I was wondering if this whole process, consent process, take place when there is the first contact with somebody from the ketamine clinic, or if it's something that is done more when released just before the infusion, or if it's split between the two times.
Yeah, that's a great point, especially with some of the implications I think that you're talking about as far as initial medical psychiatric workup and screening. We just didn't address that in this analysis.
And then I was also wondering if, but I think we have maybe some Q&A first. Yes, we have a question from Tiago. Do you think that ketamine should be regulated by Anesthesiology Society?
Not quite sure how to answer that question. I am curious maybe to hear more of Tiago's opinions on that. I don't know if there's an easy way.
I tell you what, I wonder whether, given the nature of this particular topic, should we just bring it up as a panel discussion straight away? I think that's going to work better for this. So we'll try and just bring all participants over as panelists, so that, you know, everybody can just ask their questions, and we can try and get a dialogue going here. I mean, this whole issue speaks to the issue of standardization and regulation, doesn't it? You know, I think it's a terrific sort of first step. And perhaps just while we're bringing people over, just to give a sort of flavor of how this can work. So obviously there will be some medical societies that have panels of people, of experts that actually derive standards for what a consent document should include. You know, they can be quite prescriptive, and in a sense, your analysis starts off by, you know, it has implicit within it a set of standards.
Yeah,
I find myself thinking, well, why should a consent document only have, why should it pass muster if it's got 2 out of 3 of the long-term side effects mentioned? I mean, you know, it's perfectly reasonable to set your mark somewhere, but of course we could all argue about exactly where that mark should sit, and I would like a consent document to cover all 3 of them. You know, I think it should. That's my personal opinion. But
one thing,
perfectly reasonable to start with you know, if you're going to start marking them, you know, you've got to draw a line in the sand somewhere. So I'm not criticizing you, but I'm just saying this sort of approach as to what a standard should look like is, you know, it sort of has to emerge from a group somehow, doesn't it?
one thing I do appreciate about the ASKP standard that we used is my understanding that is a very interdisciplinary, cross-disciplinary group of mental health providers, anesthesiologists, emergency medicine physicians, internists, so on. And I think there's a lot of value to kind of having those broader conversations as we develop some of these standards. For example, individuals with psychiatric training might be able to better brainstorm some of the ideas around psychiatric and psychological support in comparison to anesthesiologists who might be better informed to talk about some of these medical parameters, respiratory safety, cardiovascular safety, and so on.